Noon. Good afternoon. I'm Dr. Q English. I'm the director of the Center for Faith-Based and Neighborhood Partnerships at the United States Department of Health and Human Services. So I'm looking forward to leading a conversation today about a new set of reports from March of Dimes that show that where you live matters in terms of your ability to have a healthy pregnancy and birth. First, I definitely want to welcome those that are joining us in person and the over 800 that has registered online. So the Where You Live Matters Maternity Care Deserts and the Crisis of Access and Equity is a new set of reports that finds more women are struggling to access care before, during, and after their pregnancy journey. March of Dimes Maternity Care Deserts report, released every 2 years since 2018, combined with this latest analysis, represents some of the largest body of research of its kind on the state of maternity care in the United States. And data is at the heart of this new set of reports that paint a picture of how women access care in this country. These reports find that more than 5.6 million women live in counties with no or limited access to maternity care services, forcing families to find new ways to get the care they need. So more to come on the report and its findings soon. But before we start with our discussion, we wanted to start by playing the video produced by the March of Dimes, which highlights the challenges of maternity care deserts in rural Georgia.
It's kind of what you just have to deal with living in Troup County, but it's not okay. And we are actually closer to Valley, Alabama than we are to any medical care that I need, especially during my pregnancy. Troup County has a very low access to maternal care, maternal post care. It's even starting to affect when it comes to our pediatricians. Being in West Point, we don't have any OBGYNs here. So my primary care OBGYN is actually also in LaGrange. That is about a 20 to 25 minute drive for us. And it's kind of nerve-wracking to the point where I've actually spoke to my doctor about being induced. That way I don't have to worry about that drive and pain or fear that something's going wrong.
We are the closest hospital for about 4 counties in this area. So not only do we serve Troup, but we also serve Meriwether, Coweta, Harris, and Heard counties. Statistically, we know that women who have to travel further for care are at a much higher risk for adverse perinatal outcomes. I'd say probably about 70% of my population of pregnant people are high risk.
20-25 minutes that's an extensive drive in an emergency. And even if you're looking at waiting on an ambulance, that's 10-15 minutes to get here, another 20-25 minutes to get to the emergency room.
We're thinking about how far away someone is from a hospital. You have to think about their access to urgent care. And in these small rural areas where people live, and there are hospitals that are not equipped to take care of obstetric patients, then that can really be a serious problem.
To people in low access areas, it's a struggle. And if you're not in that struggle, then you don't understand. Not everyone has that same equal medical care, that same equal accessibility. We can have the same doctor, but we don't have the same journey to get to this doctor.
We've seen this landscape change over the past 30 years in terms of labor and delivery units and OBGYNs available in hospitals across the state of Georgia. We've had at least 35 closings over the past 35 years of labor and delivery units. You end up having whole communities and whole swaths of areas that don't have an OBGYN provider at all.
So let's begin the conversation. Joining us in this much needed discussion is Carole Johnson, the Administrator for Health Resources and Services Administration, also known as HRSA, Dr. Elizabeth Giroux, the President and CEO of March and Dimes, and Rose Mitchell, the Nurse Midwife and Doula, Albany, New York. So I want to start with Administrator Johnson. If you can just provide opening remarks, followed by Dr. Giroux, and concluding with Rose. Thank you.
Thank you so much, Dr. English, and thank you to Dr. Giroux and to Rose for being here, for all of you who joined online, and frankly for everyone who does this work every day to expand access to care and services for pregnant people, not just in the healthcare delivery system, but in the social services that are needed in the community to ensure we have the safest possible pregnancies. I think it's important for us to thank the March of Dimes for putting on paper what we all know. And you know, it is, and it makes a difference. I think that a lot of women or people of childbearing age know this more acutely than others. I mean, I've had that conversation with folks who are not of childbearing age, and this is news to them. And we need to make it so it's not news to them, because that's how policy changes. But I do want to start with noting in particular this administration, the Biden-Harris administration's strong commitment to addressing the maternal mortality and morbidity crisis, and that means access to care. And I can't overstate for you how dedicated the leadership of this administration is. The president has called on all of us to use all levers across government to address this crisis. You all know, because you're in this field, that this is close to the heart of the vice president. And she convened the first cabinet meeting that's ever been held on maternal health. I had the opportunity to join that meeting with Secretary Becerra, where sitting next to me were folks from the EPA and the Secretary of Labor and the Secretary from VA and the OMB director, the critical OMB director, where the vice president pushed on if we have a doula workforce, we build a doula workforce. What can the Department of Labor be doing in addition to what we at HHS are doing? What can transportation, and in particular Secretary Fudge was there, what can housing be doing to ensure that we address the critical housing needs that we know are important to good health outcomes. And so from that work, as you know, we as an administration have launched what the White House calls the Blueprint on Maternal Health. And that blueprint really has laid out a pathway for all of us. We are shoulders in, leaning in, trying to pull all levers across government. What we know is important. So for example, we've made critical steps in expanding Medicaid access postpartum to 12 months. This is a vital part. You know, it doesn't make any sense. We were actually at an event recently with the secretary where a young woman said, you know, I felt like that was a statement about me and the value of my health care when you said my health benefits were cut off after 2 months. Like that, it didn't matter anymore what my health was. So not only is it a matter of health outcomes, it's a matter of principle that we ensure people have access. But a card alone is necessary but not sufficient. We need to make sure that there's a place with high quality health care where that card actually translates into good healthcare services. That's why we at HRSA have been investing in strategies like AIM strategies and pregnancy bundles to make sure that healthcare facilities are prepared for and ready to respond to any crisis, any pregnancy-related challenges inside the clinic walls. But that's only part of the equation, right? we need to make sure that we're thinking across the spectrum. But too many people are not, we don't identify and make it easy enough for women to get into care early. And so people are coming into prenatal care later than we'd like. And we know that that makes a difference in care delivery. We also know that after pregnancy, we often treat the mom or the pregnant woman or the postpartum woman and the baby as two different things and have different healthcare systems for them, as opposed to that, it's already hard enough to get to your healthcare visit when you need to find childcare for your other kids or transportation or ensure that you can take time off work to be able to do it. We need to make it as easy as possible. And we need for the system not to be designed in a way to say, well, women need to do one more thing and it would be better if they could do this or they could do that. We need to make it so that the system, we own this. Women don't own this challenge. We own this challenge as policymakers, and we need to make sure that we are wrapping services around women and making it as easy as possible for them to get the outcomes they need. And that depends on a robust, high-quality health workforce. What we're doing at HRSA is making sure that we're investing in not only making sure that we're using our National Health Service Corps, where we do scholarships and loan repayment in return for practicing in high-need areas. We're using that program to drive OBs to high-need communities. I was out in rural Maryland not that long ago, where the only place for hours around where deliveries were happening were because a National Health Service Corps OBs were in that community. And what we do in that program is we provide loan repayment in return for a service commitment for practicing for a few years in the community. But inevitably, people build their families there and they stay there, and there's roots in that community, and people tend to stay where they train and where they initially practice. And so we're going to continue to use, Congress has given us some authority to create, in addition to our health profession shortage area calculations, maternal care target areas that we can use as part of our National Health Service Corps to continue to drive not only OBs, but family medicine providers who provide maternal health care as well. We know that that's part of the solution and equation here in rural communities. We also are the home of the Rural Health Policy Office in the department. We fund the Rural Health Moms program, where we are getting into rural communities to build networks and solutions across the table. There's lots of pockets of good work. We need that to be coordinated. We need that to have a focus on how we build sustainable systems that are Medicaid reimbursable. We're also using our workforce programs. We fund a ton of training programs. We have committed more of our nursing money to training more midwives. We are using our maternal and child health resources to train and support more community-based doulas. We are funding state innovation programs to put more leadership at the state level around a table together so that we have common sets of data, so that we are identifying where the real gaps and challenges are, and not lots of little pockets of money chasing different issues, but we have a shared vision and strategy for what that work needs to look like. We also know, and we can't leave out of this equation, the mental health needs of women, and that we fund a program called the Maternal Health Screening and Depression Program. We're doubling the funding for that this year. We hope, as Congress now has a new speaker, it sounds like, we will be able to continue to grow those resources. But it matters. It matters that, that we get there, and it matters that we continue to grow those programs. I will tell you, I think that, it won't be news to folks around this room, programs that we fund, that we have, as this administration, really leaned into growing the support for. We've doubled the resources in the home visiting program, which gets nurses and home visitors into voluntarily into new families' homes early on to help with early childhood development. That is so important for postpartum women. It's really important for women who have multiple children and are newly pregnant to be able to continue to have that resource to support on childhood development. But we also are the home of the Healthy Start program, and the Healthy Start program is so many communities across this country. I just visited one not that long ago where not only are they doing home visits to pregnant people, but they also are ensuring that food is available for those who are food insecure, ensuring that they have tenant services and supports to help people understand how to read a lease, how to make sure you're getting into a good environment when you're trying to get stable housing for you and your family, how to have community support. That is a program that was zeroed out in the Labor Age House Bill. And so there's a lot of work that we need to do to really focus on how we bring together all these critical needs that we know are a priority, and that we can continue to succeed in that development going forward. I'll just flag two other things that we're doing. One is last year we launched the National Maternal Mental Health Hotline. That number is 833-TLC-MAMA, which is 833-852-6262. We've gotten an innumerable, the calls that we get are really compelling, and the need is real, and having a safe, confidential space for people to call and get the kind of support that they need is filling a really important gap that needed to be filled, and we're really excited about that and continuing to work to spread the word about that resource. In addition, we just made $90 million in awards across the maternal health continuum, including everything from training more nurse midwives to supporting more state innovation awards. But one of those awards was to create a research network around the country focused on maternal health disparities. We know so much of the research that has been built up in clinical care doesn't actually look like the folks that we're talking about. Like, it needs to look like the community. And so Morgan State will be the anchor research institution, but we'll have a ton of facilities, a ton of academic centers around the country really focused on this research. So much more to do, but know that this administration is as committed as we can be, and we are putting all of our resources and policy levers and power together to try to address what we know is an absolute critical need. Thank you.
Thank you, Administrator Johnson. Truly our champion here at Health and Human Services. Dr. Carole?
Well, first, thank you for having me, Dr. English. It's fantastic. The March of Dimes is committed to the maternal and infant health crisis. As I think most of you know, we're an 85-year history of a non-for-profit that started in polio and then transferred over to birth defects and preterm birth, and now the maternal health care crisis. And as I sit here today, I think about what the March of Dimes really is and does. I got asked by colleagues as I joined the March of Dimes in January, as I'll get into in a minute, but I got asked by the people that I've worked with in the past and said, what lane does the March of Dimes swim down? And my favorite answer to this is, we actually aren't down a swim lane, we're the swimming pool. We like to be the convener, so thank you, everyone for being here today, to bring partnerships together. You know, I could get into an analogy where there's certain chlorine levels, there's clarity, maybe there's warmth, the lifeguard, but I'll digress. And just say that being a convener, it's important to make sure that we're good partners, both to the communities that we serve, but the partners that we bring together. And it's going to take that to solve this problem. Just as we have been around for 85 years, one of the biggest things we did is we solved for something, right? We funded the research that solved for the polio vaccine and eradicated that from the US. So I think about what we could do, which is why I joined the March of Dimes in January as the chief medical officer, and then became the 6th president, which is kind of fascinating to think of, but founded really by a president asking for donations to the White House, including a dime, which is now $1.85, by the way, today. Just throw that in there. So, and FDR, right? So love what this administration is doing and leaning in with us. And so having been the chief medical officer for all of 6 months, said, sure, I'll be the CEO. Let's go for it. And so the first physician, and I'm an OBGYN. I've been practicing and delivering babies for almost 30 years. I started in private practice, dabbled academics, did some really cool, fun projects, and really believe that the next thing that we'll be doing is really looking at the different innovation and growth across our platform. So I want to turn to kind of what we do, right? The March of Dimes does education. We were discussing this a little bit before. We are also obviously in policy, and we also do a lot of research still, and is our backbone, which is where I think this is when I start to think about research, it's about data. And so here today, we're here to amplify what I think we do amazingly, which is our Maternity Care Desert Report. Yes, we've been reporting since 2018. This is a newest report and isn't every 2 years. This is an extra supplemental that really dives into the county level. At the 5.6 million women are just the starting point. When you start looking at where we go, if you look at the report itself, visually it's beautiful because you can immediately see where we need to drive some of the things that we're all doing to be really calculated about where we could make the difference. I think one of the things that's fascinating to me is that a third of our counties are maternity care deserts in this country. We have places that there are no counties. Women are driving way beyond 30 minutes to get care. I also think, and thank you for whoever's driving the slides to go right into, because I probably can see exactly where I'm going, that our report really dives into this time a lot about chronic conditions. And why is that important? Because that impacts preterm birth. I can tell you that we are going in the wrong direction. And the other aspect of this is really getting into the data that we look at, that 2 women are dying every day in the US. And I'll just pause there for a second to absorb that. 2 babies are dying every hour. When you look at this through the lens of race, babies that are Black and brown are 2 times more likely not to make their first birthday. That's a problem. We can keep going about how we have gone in the wrong direction for the data from the CDC, which we've pulled out. Also, the 2.2 million, the difference between that 5.6 and 2.2 is 2.2 million live with absolutely no hospital within their county. And then we've got the 350,000 babies that are being born in those counties. And we know that when you start looking at race and you start adding chronic conditions, your preterm birth only accelerates. You think about that from that perspective, where we start adding race, you start looking at an exponential rise in preterm birth. And I'm going to put a shameless plug into our November prematurity report that will be coming out. We do it every year, and that's coming in November. You'll see the data then and be just as shocked as I'm reporting them today. So I think we have one more slide. And so this is the definition of maternity care desert, because I think it's really important to understand this is where there is no provider, so that family practitioner, that OB provider, that midwife, or hospital or birthing center to deliver at. I think it's really important to understand the impact of inadequate prenatal care. We know those are the women that have the highest risk. They have the worst outcomes. If they have, I think about the people I have served who have come in with emergencies that imagine driving, I think it's North Dakota, it's 150 miles. Think about the Alaskan woman who has to take a plane, or in Hawaii, same thing. Just start thinking mentally about that, where 60% of these are actually rural and 40% of maternity care deserts are inner city. So it isn't just a rural problem. Right. So last, I'll get to what our policy solutions have been. This report, again, goes through some data on, and I'll get to it, I'm sure we're going to talk about a little bit on the report itself, but really talking about how some of these solutions, like telemedicine, I think of pre-COVID, right, and how I never used Zoom, and then all of a sudden I'm doing amazing care through Zoom. And we know that this is something that can have big impacts to our most vulnerable. And so how do we get access to these high-risk women is knowing that they can benefit from telemedicine. And that they could not, so we know that in 44 states, we've enhanced policies that have permanently expanded Medicaid telehealth coverage. But think about those that have not. Call out a state or two, but I won't do that. The perinatal, we've regionalized. We've also expanded healthcare workforce, which is super important. I know we're going to talk about that a little bit today too. And then our Medicaid expansion. We all know a postpartum woman does not recover in 6 weeks. Okay, if you don't, come talk to me later. They don't. And we know it's a mental health. We know that that's an opportunity to make a difference. So I'll conclude there and just say, please come join us in the swimming pool.
Rose?
Good afternoon. Thank you, everyone, for having me. Thank you, Dr. English, for moderating. I really want to thank the March of Dimes for bringing me down here for this event, for bringing this event together, for the report. On a personal note, I want to thank Darcy Dreyer and Catherine Mitchell, who are two March of Dimes staffers, who were very helpful with the effort that I am going to be talking about after I introduce myself. So I'm here from New York State. I live outside of Albany. I am a licensed midwife. I am a retired but still certified birth and postpartum doula. I am actually not a nurse. I can talk a little bit about my educational background, but I am a certified midwife, which in New York State earns me licensure at the same status as a certified nurse midwife. And I'm also a wife and a mother of two. And additionally, I'm a longtime activist and advocate for reproductive justice and human rights in childbirth. When I was 13, I attended my first Take Back the Night rally in Albany's iconic Washington Park, and I have been a pain in the butt of everyone I know since then. So specifically, the experience of giving birth in America was a very galvanizing one for me. My oldest son is 14. Anyone who's given birth knows how intense that time period is. Learning to become a mother in the context of healing and recovering from pregnancy and birth is a very, very tall order. And personally, it galvanized me to join the fight for improving birth. So in those first few years of pregnancy or of motherhood, I came to see that pregnancy, birth, and postpartum, which are incredible moments of transformation for any individual, are really profound opportunities for us as a society to nurture healthier individuals and healthier families and healthier communities and healthier societies. You see where I'm going with that. So I dug in and directed all of my focus towards that effort, and I became a doula and worked in that field for the better part of a decade before answering the call to midwifery, which I saw as a personal, a personal calling, and also just a broader, more political calling that I had the opportunity to serve more people and serve the broader community than I did when I was a doula, and so I took that, I answered that call, and here we are. I am a new graduate. I graduated last year. Thank you. So I'm still very much in the early days of my career as a midwife, but I have promptly returned to activism now that I'm no longer juggling schoolwork and family life. And speaking of answering a call, in May of this year, one of the local hospital systems in the Albany area announced their intentions to close the Burdett Birth Center, which is a level 1 maternity unit in Troy, New York. It's the only labor and delivery unit serving the city of Troy, all of Rensselaer County, and in fact, much of the eastern edge of the state. When that announcement was made, a grassroots coalition of birth workers, healthcare and public health professionals, community members, lawmakers, and advocates came together to stop this proposed closure. The coalition activated the larger community, who sent letters upon letters to the state health department, which ultimately will be the entity that decides whether or not to approve this closure. They sent comments to the Attorney General's office, and they've come together for forums and rallies in support of the center and the wonderful dedicated staff there. And they've also generously shared their stories in an effort to illustrate how special the Burdett Care Center is. So our coalition carried out a robust grassroots health equity impact assessment, which surveyed and interviewed many members of medically underserved groups, showing unequivocally that this closure would negatively impact health equity in Troy and the surrounding regions. Burdett's parent hospital hired an independent consultant to conduct a health equity impact assessment of their own, voluntarily, although under intense public pressure. And theirs was actually just submitted on Monday. And I don't think it's as thoroughly researched as ours is. Personally, I am biased. But I will say that they do reach the same conclusion, which is that closing the center will only harm the community. And they also stated that multiple times that 98% of their 750 survey respondents oppose the closure. So I will happily talk more about the work that we've done in Troy today, but I do just want to circle back and offer my congratulations to the March of Dimes for this incredible report. Where You Give Birth Matters is a complete sentence, and it also is a tremendous piece of research. As a persistent optimist, my favorite section is the list of policy solutions and actions. And I've been advocating for the midwifery model of care for a very long time. It's evidence-based, it's effective, it's inexpensive, and it's in demand. Midwives are primary care providers as well as experts in normal birth. We can work in both hospital and community settings. We are trained in multidisciplinary collaboration, and we are also much quicker to train than surgeons. But in order for the model of care to proliferate, we need more midwives. Midwives train other midwives. We need to address barriers to midwifery education, especially those barriers that are unique to or more prevalent in BIPOC communities. We need to ensure that students are able to finish their training. One very real issue that midwifery education is facing right now is a critical shortage of clinical training sites that existed prior to the pandemic but got much worse during the pandemic. And it's created a bottleneck to people graduating on time and getting out into the field and practicing. So how about some funding to support clinical preceptors in the form of honorariums and professional development? We need national initiatives to ensure that midwives in every state are able to work to the full extent of our training. We need to support healthcare systems in incorporating midwifery into their cultures of care, not just into their facilities. And we need to decide together as a society that women and birthing people and babies matter, and we need to fund their care accordingly. Thank you.
Thank you, Rose. So maternity care deserts in the crisis of access and equity. I'm going to circle back to Administrator Johnson. You really answered a majority of the next question that I have. But as we dig deeper in understanding access to underserved and the rural areas, can you talk a little bit more about what HRSA is doing in that space?
Thank you so much for the question. It really is terrific to be on this panel and to have the chance to have this conversation. I do think I went off one stuff, a couple of things. That was a really gripping picture of a rural area, but that's not like that we're past that point now, right? Like rural areas, urban areas, ex-urban areas, this is happening everywhere. You only have to Google labor and delivery closure. I do it like once a week. There's someplace else that's popping up. There's a real challenge across the country. And so what we're doing in the short term is we have been investing in deploying mobile clinics and expanding access through our community health centers. Community health centers, which we fund, there are 1,500 operating 15,000 service sites around the country that see people regardless of their ability to pay. We're continuing to build and make new investments in building our maternity care capacity in health centers to be able to provide prenatal, postnatal care in partnership with local delivery sites. We are, again, we're focused on the workforce, the continuum of the workforce. So while we're doing scholarships and loan repayments for OBs and midwives and others, we also are investing in family medicine providers and making sure family medicine providers have the skills and capacity to be responsive here, as well as we're increasingly thinking about what do ER doctors need to know, and do they know as much as they need to know? And we have built emergency response services in obstetrics units. Like, do EDs need those now? Because people are on the road for much longer times than they otherwise would be. And we're building, and so, but all those things are Band-Aids to the larger systemic challenges around the fact that the numbers don't always add up anymore for service delivery providers. And so while this is an acute challenge, absolutely in maternal health, we're seeing it in healthcare services across the board when it comes to rural hospitals and rural hospital potential closures. And so Congress last year worked on some legislation to create some new options for rural communities, new sort of facility options, and we do a ton of technical assistance and support in rural communities to help them figure out how to hold on to their facilities, how to do the real world financial analysis that their CFOs do, but to figure out how to do that in a way that ensures that they can retain these critical services. So I think this is a ongoing, everyday, real world challenge, and we're going to have to keep at it, and are constantly looking to expand the set of policy options that we are delivering on, and really partnering with Medicare and Medicaid on this going forward, so that we can continue to be that critical link in reaching underserved and rural communities. And then I'll just finally come back to the point about underlying health conditions. We know diabetes, hypertension, mental health, substance use disorder, these are real challenges for everyone, and then become critical challenges in preconception and interconception care, and which is why it's so important that the resources that we commit to building the primary care infrastructure in communities through our community health centers is so important. And then the workforce that delivers that care, that is a set of funding that expired at the end of September. And so we are working hard with Congress now to try to sustain those resources going forward, because that's a vital part of this challenge as well.
Can I do a follow-up question to that? With the amazing programs that are being launched through HRSA, are there, and obviously the situation we're in right now with Congress, et cetera, but are there any new funding opportunities on the horizon that we can consider this time?
I mean, well, there's new funding. There'll be new funding opportunities if Congress delivers on President Biden's fiscal year 2024 budget. One of the things that we have been asking Congress for some time is to provide us with resources to invest directly in community efforts to support social determinants of maternal health.
That's excellent.
How can we support community-based organizations to really tackle those social support challenges that make a difference in safe pregnancy outcomes, that make a difference in early engagement in care? So, we're hopeful. Look, we're really hopeful that we get new resources for Congress, but we're also at the same time fighting to sustain the resources we have. And so that's the sort of the moment that we're in right now.
Thank you, Administrator. Dr. Carole, when we talked about the data, what does that data look like this illustrate that we wouldn't know otherwise? And what was most surprising about the report to you?
Well, first, this report, if you look back compared to 2018, goes into county level data, which I think is fascinating.
Yeah.
I think visually you'll see it really pops on I have to give a big shout out to our perinatal center and how much work it went in to get this done. I would articulate that the report itself not only talks about the miles to drive to an obstetrical services, but it also talks about family planning, which is different. I mentioned the chronic conditions. That is something that surprised me, that count across this country is 37% pregnant people have a chronic condition. We are really getting into high risk when you start talking about, having to manage diabetes or hypertension. Those become critical And getting that access is so critical. I would also tell you that we look not only into chronic conditions, but we do get into issues around poverty. And what does that look like for moms? And I think it may be very obvious, but those are some of the areas that we know we need to impact. So when you take this data and you start thinking about, and I think about the mobile units you mentioned, because we do mobile units, only 2% of all mobile units are in maternity care. I find that fascinating. We're a convener, right? So I'm not a provider, but we put the mobile unit together. We bring in partners who will fund, who will donate not only, ultrasound machines and time, but we bring in the social worker, and we try and put it all together to be able to get to the patients where they're most needed. And these are patients that would never have gotten care otherwise. When we start looking at the impact that has is tremendous. So I think about the data and not only how we present it to everyone, but also about how we can now target where we should be going. And I think you can see the swath in the middle of this country. So I could get into more data points, but whether it's Texas compared to California, but it really, I encourage you, whatever state you're in, to look at, but then also go to a state you've never been to, or that you would guess might have an issue or not have an issue, and really look at it. Even just if you flash up from the county map, it's a heat map. And I think it's striking, and it's heading in the wrong direction, while our numbers are getting worse. So that's what shocks me, is that we are not improving.
And to that point, Rose, let's continue the conversation of some of the things that you've been observing, and as someone who serves in the community, how hospital and birth center closures affect access to care, and what are the impacts to families getting the care they need. And as you speak to that, can you talk about the circumstances, specifically in the Albany, New York area, and the potential short and long-term effects on access if closure moves forward?
We can also look back. We have the picture of where we're at now and what we anticipate what we anticipate the effects of this closure will be. But we also have historical data. We were able to look and the team of people who are very good at things like PowerPoint, who are in this coalition, are really skilled, and they created these slides that just showed the maternity centers disappearing every decade, and at the same time the maternal mortality rate just steadily increasing across the country. So this is a complicated issue, but it's also quite straightforward. 1 + 1 = 2, right? If you're going to take something away, that is, the birth rate might be declining, but it's not in a free fall. People are still giving birth. So when you close one facility, it puts a tremendous burden on the neighboring facilities. And so what we're dealing with is a hospital system that claims to be able to meet the needs of all of the community, without actually illustrating how they're going to do that. So we held a community forum where local nurses and hospital staff were asked to speak, and they shared how their facilities are already working at or beyond capacity, and it does not feel safe as a provider or as a nurse or whatever, as an EMT, that there's fear that around any corner there's going to be a massive gap and your patient's going to fall right through it. So closing one facility simply means putting a greater burden on the next closest one. And so Burdett, for example, delivers 800 to 1,000 babies a year. And the parent hospital, which is just across the river in Albany, delivers over 3,000. And they have very casually just declared that they are going to have no problem whatsoever absorbing that additional 1,000 births. That's 25% of their patient load. It doesn't add up to me and to many people. We've demanded full transparency. We're waiting for that. The transportation issue, of course, is one that this report has brought up, and it's very real in our area. And we're not in a region like, for example, like New Mexico or Alabama or Louisiana, where people are really driving hours to get care. But when you have an emergency, it doesn't matter. 20 minutes, it can be the difference between a live baby or an unalive baby. It could be the difference between postpartum hemorrhage that you can bring someone back from or not. So, we're looking at a potential closure in an area that has already had closures. The whole city of Troy has experienced consolidation of services in the last 10, 15 years. A few years ago, the county immediately south of Rensselaer County, Columbia County, lost their labor and delivery unit. The local hospital conglomerate that bought that small hospital closed that unit and brought all of their delivering patients up to Albany. So we're seeing the units disappear and the drive times increase. Now, when you're talking about social determinants of health, this is something that we absolutely cannot have this conversation without considering. We've learned in our research that 22% of households in the city of Troy do not have cars. And ours is not a region where you can just hop on a bus or call up an Uber any time of day. And we're not New York City. We are cities, but smaller ones, less resourced ones. So a bus ride between downtown Albany and Burdett is 10 to 15 minutes, but no, I'm sorry, downtown Troy, I misspoke. But to get to one of the other neighboring cities' hospitals is going to be a bus ride of at least 45 minutes. It's going to involve at least one transfer, and those buses don't run all the time. They don't run all night, and they have much limited hours on the weekend. So to paint a picture for people who don't really understand what it's like to be pregnant, if you are going to the hospital during your pregnancy, but you're not in labor, it's because you think something is wrong. And it could be very, very wrong. Something could be very wrong. And so can you imagine waiting at a bus stop, wondering if your baby is alive? Or if you yourself are in grave physical danger because of your pregnancy? Or let's say you are in labor. Do you want to be at a bus stop? Or anywhere, any motor vehicle. You don't want to be in a car, in a bus, on a train, or in an ambulance while you're in labor. You want to be as comfortable as you can. So we are asking people to imagine scenarios that just don't belong in modern society. I cannot believe that in 2023 we're having this conversation still. But then there's more to the transportation issue that gets even scarier when you talk about the broader implications for the community. So we were able to connect with the Troy Fire Department. The president of the fire department union shared with us that they only have 4 ambulances in their department. And so they are already overburdened with patient load, and they don't have enough staff and they don't have enough machinery to transport patients right now at baseline. And so when they are asked to transport someone who lives in downtown Troy who's having an obstetric emergency to Albany or to Schenectady, to one of the next closest hospital that can take care of these patients, they're going to be waiting. The 2 hospitals in Albany were shown to have the second and third longest emergency room wait times in the state. So those ambulance drivers are getting calls in the city of Troy because someone got in a car accident, or because there's a house on fire, or because someone got, stabbed or something. Whatever the case may be, those emergencies will continue to happen. And those providers, those EMTs and firefighters, those first responders, they have an impossible situation. And so it's a public safety issue, in addition to being an obstetric and moral issue.
I appreciate you sharing, Rose. And I think what's important, you're hearing it's not getting better. And we're all sitting here like, it seems like we're going on a deeper slope, right? However, the education and awareness is critical. For those that are listening online, for those that are in the audience, we're hearing from federal government. We're hearing from the March of Dimes that has another path. And we're also hearing from the advocacy lane, which tells us that it's going to take all of us working together in this space if we want to see change. And I want to open up this question to all of the panelists. when we think about on a community level, we're thinking about the closures and we're thinking about, or the deserts, what is the impact of maternity care deserts really on the community itself? Administrator Carole, you want to take a stab at that first?
Well, I think it's been articulated across the panel today. I mean, one of the things that is noteworthy to us is the amount of work and need as we do more and more work on maternal mental health. And so as we try to support pregnant people both before and then prenatal, during pregnancy and postpartum, the maternal mental health needs are significant. And part of what we want to do is reduce strain and stress and areas of concern so that people have the best possible physical and mental health outcomes at this critical juncture in their lives. And so things that make that experience more stressful are bad all around. Yeah. And so we need to be doing not just what it takes to make sure that there's a good, high-quality healthcare provider at the other end of where someone gets to, but that someone can get there and can get there relatively easily and feels comfortable and safe and in an environment that allows them to not have the negative outcomes that we were all so concerned about. And so, there are real-world consequences for what happens here. And I think, we are continuing to make sure that we're building that infrastructure and that we're building those supports.
Thank you. Did you want to chime in, Dr. Chabreau?
Yeah, I would just dive in and say it's the ripple effect, right, of all of it that this has to moms, families, and really what I think about is that moms make most of the decisions for the health of their family, so we're not prioritizing that, and that ripple effect for the rest of the family, the healthcare worker, all of them, it's all wrapped together. I think as we hopefully change the course and refocus as that, we help one family, we're helping all, and that sounds simple. It's certainly complicated, and there are layers this onion to get to and to solve for. But I think that ultimately is the aim and the goal that I think all of us here at the table have. But I think thinking about the ripple effect, whether it's the neighboring hospital, whether it's the ambulance system, whether it's the healthcare worker who might be burnt out, there's just there's a lot to address. But to me, it's very clear that we've got to put mom and baby at the center of this to solve for it. So.
Yeah. I appreciate that. And as we're thinking about, you made a comment, Dr. Chabreau, about some of the things that we're doing has been more of a Band-Aid effect, and this is much more complicated. But in our closing conversation, before we turn it over to audience participation, where do we go from here? Some of the things, action steps that we can take. Obviously, we're talking government, but we're also talking community that's joining us today. Why don't we start with Dr. Chabreau from the where do we go from here, Rose, and Administrator Johnson, I'd like you to conclude that. Thank you.
March Times is doing programs like advocating for midwives. I am thrilled that 19 states, right, have healthcare workforce programs. I have my lovely list of 4 states that have programs to support emergency obstetrical training. We've got 3 states that have a Project ECHO, which is the extension for community healthcare outcomes. It's really getting high-risk OBGYN, care. And I would talk about Delaware providing coverage for women for 2 years for postpartum. How exciting to think about. So, because I don't want to end on doom and gloom, because it starts to get, right? We really got pretty gloomy there. So thinking, right, what, right? Yeah, it starts to go heavy. Like, oh my gosh, the burden of this is a lot. Yeah. So think about where we are. I'd love to see where Delaware goes with their outcomes data. That will be fascinating to look at. For future. So when I think about extension of postpartum, when I think about extension of telehealth, some of the things that we can really do to have impact. Again, mobile units, I'm thrilled to hear, because that is something that I think actually can get to patients where they are. It's like having a pop-up clinic, right? So my pop-up shop for my shopping, I can do this for my patient care. So you start really thinking about some of the things we're doing. We're looking at data on doulas. We've got a 3-year program right now, really trying to figure out how do we retain, train, and integrate doulas. Doulas are not the only solution. Midwives are not the only solution. So with all these complex parts of the onion that we're talking about here, we're trying to get into the community to make sure that we're being really hearing from the people behind the data. I think that's really important to recognize that it shouldn't just be all of us. Or we've got to hear that and address at that level. I could keep going, I think, Dr. English, but I'll let the rest of the panelists answer.
Okay, thank you. Rose, and then we'll end with Administrator Johnson.
Sure. I do have a lot of hope. I guess I don't think I would have become a midwife if I didn't inherently possess a good amount of hope. It's easy to get quite cynical about humanity in general if you read the news, but that melts away pretty fast when you have a newborn to sniff. So I think that I've been thinking a lot, wondering, are we in the Capital Region fighting this closure? Are we Sisyphus pushing a huge stone up a hill forever? Or are we David, who's about to take out Goliath? I would like to think that with all of the momentum that we've built and the immense support that we have from the community, that we're maybe not quite a Sisyphusian tale. So people keep having babies, and I have a huge amount of faith in humanity for that reason alone. And even in the most complicated cases, babies come out. So I think, as Dr. Shiro said, there isn't any silver bullet solution. Now, I would argue that there is, and it's several $billion. So just whenever we could get that. we have plans for it.
This is our advocate here. Administrator Johnson.
Yeah, I think it's so important that we come back to patient-centered care and what patients need. And so when I meet the mom whose life is different because Healthy Start gave her the tools and supports to be able to get the support she needed early on, everything from basic services to basic substance needs. When I see the parents pregnant women who are getting care in a very rural community and in migrant communities because the National Health Service Corps got an OB into that community. When I meet people who get their care in a health center and are able to get access doula services that we're funding there, or are connected to a community health worker who's supporting them getting their follow-up services and getting connected to care, or when I meet the folks who are running our rural moms program and are figuring out the distance problem by working on telehealth solutions, by leveraging the president's investment in broadband to get better access. Solutions are there. When I meet the folks who are deploying our mobile units, we're working on all of these fronts to combat this problem and these challenges. And I think we need to lift up the people who are doing that work and celebrate the fact that solutions are possible that we can continue to spread those solutions.
Thank you. Put up for our panelists. There is hope, and that's what we're hearing over and over again. I'm going to turn it over to those that are in the audience if you have any questions. I want to start with a question that we did receive online. Megan asked, what are the biggest reasons we are just losing these medical care in these communities? Why are they closing? What are the biggest reasons for that? Megan asked. Dr. Shiro?
I'm happy to start, at least it's a financial issue, right? Labor and delivery doesn't really make money. Compare that to a cardiac unit. There's also staffing issues, nursing, right? Being able to staff labor and delivery as well as providers. And you referenced getting providers out to these communities. So these hospitals and these birthing centers are closing for a lot of those reasons. And the birth rate is definitely flat. as it is in other industrialized countries that aren't having this issue, however. So we also have to think about models of care. We've leaned into that a little bit on this panel. So those are sort of how and I go right to the financial model right away, just from, I guess, maybe the pessimism side of me, to make sure that we articulate that. But there's a lot going on. I mean, staffing has been an issue all over. And I mentioned the burnout, having been a provider for a long time and delivered in all hours of the night with some of the highest risk patients. It's a lot that we put on our providers. So.
Okay, thank you. Question from the audience. Stop. Please.
I'm Dr. Marcia Griffin. I'm a pediatrician. So what you're talking about matters to me and the kids. And the fact that, pediatrics and OB is not a high dollar, but they are critical to our future. And so I have a question, because we started a program on the borders, San Diego down to Brownsville, to get vulnerable pregnant immigrant mothers who have arrived and babies with chronic conditions into medical care all over the country where they live. Our critical issue is federally qualified health centers are denying them because they come in their third trimester. And so can they actually do that? But what we are told is because of the incentives for payment, the federally qualified centers are trying first and second and get those numbers up. And so they're denying us getting into those centers. And so we're having to call 6 or 7 federally qualified health centers. And the other thing is I'm very excited about telehealth. Maybe this would work. But how do we get the immigrant mother who gets into that community, in some rural community, and how do we get her hooked up to Medicaid so she can't get care? And then the third thing, and I'll stop, is once we do that, we're getting them transportation. We'll do that to their first, but we can't get them into, these pockets of care. So predominantly what we're saying is, you're going to have to go to an ER, get your OBAG ready, so you can get there, but they've not had any prenatal care. So how do we get access for these? It could be skewing the numbers to later term. They're in these communities, and they are our future, I think. So that's quiet now, and love this conversation.
Yeah, I appreciate you raising the issues. I'll have to follow up with you on the particulars so that we can follow up as well. And I think you raise a really important issue about Medicaid access. I mean, when we talk about, it's really exciting, right, that we have this incredible movement on states expanding Medicaid access postpartum. They're not all there yet. And let's go back to the base ACA expansion of Medicaid. Without that, we don't get at the underlying chronic conditions. We don't get at the health. And the healthier someone is in pregnancy, that if they're not, then that adds to our complication and complex pregnancies. And if we have challenges in the community and getting access to care, we've only aggravated them. But Medicaid hasn't been expanded in so many places. So there's so much more work to do on this front.
Thank you. Yes, sir.
Thank you so much. My name is Harvey Karp. I'm a pediatrician. And thank you so much for this work. I mean, it's so incredibly and so daunting. And I think that one of the things that is so important thinking in the future is about innovation, and telehealth is one of those incredible steps forward. There are kind of two issues that have been touched on that I think need more thinking about. One is the staffing issue, because a lot of times it's a nursing shortage. And the other is the whole disintegration of the extended family, and that people are doing jobs that they should be having grandma and aunt and uncle and everybody else. That's the reality, right? We have to deal with that. That's the reality of American family. I wanted to mention this in the context of a device that we're now propagating across the country called SNOOP, which is a baby bed that rocks and shushes babies. It's now FDA de novo authorized. It's the first positioner that keeps babies safely on the back, and we all know that SIDS is not gone down in the last 20 years, and it's actually gone up 15% in the Black community. 165 hospitals use this now to support the nursing staff. And 2 studies published this year show that SNU reduces nurse labor 4 to 5 hours a day. Thousands of people get this for free now from their employers. And we're starting to work with Medicaid programs in several states to be able to do demonstration projects so that we can bring this type of support to families. Because if we've demonstrated that SNU can add an hour more to the baby's sleep, which we know is critically important in terms of mental health outcomes. So as we're looking at answering these questions, I think we have to look broadly at innovation.
Thank you.
So you're talking to someone who loves innovation and growth. I think it's fundamentally what can make the difference going forward. Though my kids joke that I don't even know how to use a DVR, but I see that as something that people think innovation is something new and rock star, where it doesn't have to be flashy, but it could just be about getting that into the hands of people faster. Right now, the March of Dimes has a venture capital fund actually innovating in a way that is different. We actually take donor money and we invest in new solutions to try and get them in the hands of people faster and try and avoid that valley of failure for new technologies. We have a really cool scientific group, and we've got a really neat VC-funded investor group that does this. I'd love to say it's just me that gets to do it all, but I get to sit in and listen on all of this and be part of it. And it is new for the March of Dimes, so it's called our Innovation Fund. Our anniversary is coming up actually this fall. I guess it's in 2 months. For our first year anniversary, we've closed 3 companies, so we've invested in 3. To be able to do that, we have an outside, you apply online, and we have a really neat and very honest, transparent process for it. And then as the March of Dimes, obviously we have to be very critical about who we invest in, but the whole point of it is really to fast track and I could get into the different companies, but I'll stop there. But it is specific to maternal and infant health only. And I just love that we're leaning into an area that I might call it sassy for the March of Dimes, right? Especially in the advent of, think of us as a research institution. I think of it as something that is constantly making us grow and innovate, which I just think is really where the future's at. I also think that the med tech industry is fascinating as its growth is taking off, especially the femtech. And thinking about that, all technology really, right, if they're working on moms, babies are part of our space. So I just love the idea. And just wanted to make sure people knew about what we were doing, because I don't think a lot of people know about that part of the March of Dimes.
Appreciate it. We got a few more online questions. Many individuals are asking questions about how do we diversify the workforce as we also address the need to address deserts and the challenges of access to care. Administrator.
Yeah, thank you for the question. One, I would say our programs already, just at baseline, are more diverse than the workforce writ large. Like, people come to our programs to serve in high need and underserved areas, often because they want to serve in communities that look like them or where they're from, and it's a general matter, in some cases by a significant amount. The individuals who participate in our programs are much more diverse than the underlying healthcare workforce. 2, we have a host of programs that are really focused on engaging people early, high school students, supporting people early on and getting them. We actually, thanks to the President's support for the American Rescue Plan, had a real surge of money in some of those programs, particularly in rural communities, and have seen some exciting things in that space. If we can get to people early, particularly in rural communities, these are very good jobs. And so if we can get people on that pathway to doing that. I will tell you, just as a side note, for a very long time, we have been funding something called our Nursing Workforce Diversity Program that helps to recruit nurses from diverse communities. That also was zeroed out in the Labor Age Appropriations Bill. So I appreciate the question, but there are a lot of things that are swirling around at this time.
Yeah, I appreciate the answer as well. Monica asked, are there pathways, programs for students that are available to address workforce shortages, pathways for students to be in this space?
We absolutely fund programs like that. We fund a program called our Healthcare Careers Opportunity Program, which is really about if you've seen an academic program, an academic medicine program, or a nursing program, or another program that has a summer program where you do like a boot camp as a high school student or something, we fund a ton of programs like that. We fund, but we also fund a lot of mentorship and and tutoring support and the other kinds of things that make it possible for high school students to get into health professions training, because that's really important. It's really important that people get the kind of support that they need to be as successful as possible. It doesn't really matter if we have a stipend program or a scholarship program if you can't get in the door because of the circumstances where your learning experience happened. But if we can wrap some mentorship and some tutoring and other supports around that, we want to do that.
Oh, excellent. So I'm sure our online audience heard that. Any additional questions from the audience? Yes, there.
Hi, I'm Sinead. I'm with the Association of American Medical Colleges. We represent 158 accredited U.S. and U.K. medical schools and 400 major teaching. Thank you so much, Administrator Johnson. I think that the main thing I took away about our healthcare ecosystem is providing access. I also know, and I'm not really familiar with these kinds. I guess my question is, how do we support rural hospitals? What roles do birthing centers play in the maternity?
I'll say two things, but then turn it to you. One, I think birthing centers have an important role to play here, and I think that we all need to be actively working and supporting in that space. Two, I will say, I think there's a role for academic medicine to play in supporting rural hospitals. And that is both in telehealth and in clinical rotations of your residents, and in all the kinds of ways that academic medicine has resources and support to be able to help ensure that rural community hospitals can continue to meet their community's needs.
Yeah, I mean, I think I'm sure you're going to want to dive in too on the birth center aspect. Let me say that I think academic centers have a major impact, right? That's who we look to in so many ways, really for standard of care, for lots of things. So I think as birth centers are built, as we try and lean on each other to have a more collaborative care across the continuum, I think of how OBGYNs have changed, right? 20 plus years ago, I would see the patient that I would deliver. Then I became in a large group, just being the one on call. Then all of a sudden it became the laborist model. So if you think about just the change of that model over the last 25 years, I think about how we should be leaning into academic centers to really help some of these rural communities, how telemedicine started as just for the consult, right, and how that has evolved. We need to do the same and work together in a consortium as collaborators to do that better. Leaning into the birth center space, I personally actually have started one, and a National Medical Association president, Dr. Lawson, another OBGYN out in Texas, started one. Love that OBGYNs are leaning in there. It's feels, I think, an amazing opportunity when built properly, when supported properly by the community, by the providers around it, both pediatricians, family practitioners, everyone has to be in, and that's a lot to get bought into, but it's absolutely a model that is expandable. There's lots of controversy over them in some ways, but they really are, I think, a solution that we need to be leaning into.
Rose, do you mind if I say one more thing before I turn to you? Just to a point Rose made earlier, I think academic medicine can play a really important role in changing the culture of care in a way that is embracing of midwives and doulas, is in a way that it thinks differently about what the care team looks like and what care delivery looks like going forward. And physician residency training is a place to do that.
That's good.
So I'm not the person with a brain full of knowledge about policy, but I can say that I am a hearty supporter of birth centers. We do not have enough in New York State. That's largely because of the way that the law is currently written. And the New York State Association of Licensed Midwives, also known as New York Midwives, has been pushing hard over the last few years to get adequate legislation and regulations written so that midwives can own and operate birth centers, so that they can be regulated differently than hospitals, because that right now is the sort of reason that we don't have more, because it's extremely expensive to build a hospital, and birth centers don't need to be classified as hospitals because they are inherently just a lower risk facility, providing just a lower level of, that sounds pejorative, it's a lower level of service. There's no surgery there, right? In terms of the broader ecosystem of healthcare right now, I think that proliferating midwife-run birth centers in particular will go a long way to restoring trust in the healthcare system. And that's a theme that's come up a lot, that came up a lot in the interviews that we conducted in Rensselaer County around why people wanted to support Burdett, why people wanted the Burdett Birth Center, which is run largely by midwives, to be, to stay open. And it was because of that model of care that midwives provide, is one that people can put their trust in. They feel safe in, they feel respected, they feel seen. It's a whole person approach. So and we know that where a person gives birth has a lot to do with how they make healthcare consumer decisions going forward for themselves and for their whole family. So I think it really behooves healthcare systems to invest in birth centers. It's good business. It's a smart marketing decision, and it will solve some of the problem of access.
Thank you. Our last in-person question, please.
Maryland last year became the 18th state to allow Medicaid access to undocumented women program. And so, but one of the things that the advocates constantly kind of there was not enough data to back up them saying that there was a need in Maryland, right? So I guess my question is how can we better collect that? How we can also just collect that data to make sure that we have proof that, right, that there's women coming into the emergency room the first time seeing their doctor 9 months pregnant, right, and why that's the need there.
I'll start, but I'm sure you have. One of the things that we're funding as part of the White House Blueprint is our Maternal Health State Innovation Awards. So we're giving money specifically to states to create state-based task forces that have among their primary goals data collection and really building a common shared data set across government and payers and providers and community organizations. Because often what we do in our grant making is we ask people to tell us about their need, and then they have to go out and find this data, and the data is sort of discordant and it isn't all. And so we at some point we have to be the ones creating the table that allows people to come together around these critical issues, so that that we have a baseline understanding of where gaps are and where needs are, including needs, as you've pointed out, and then be able to direct resources to where those critical challenges are.
Thank you. Final question from online. This would be for Administrator Johnson. Like birthing centers, Tashara asked if there are ways that we can fund more community-based solutions, like supporting birth justice and doula training that is also culturally competent.
Thank you so much for the question. Yes, we want to fund more community-based organizations, and we're working really hard. this is a little bit broader than the topic at hand here, but we're working really hard to make the front door to our grant making process easier and simpler for people to access, to make the ongoing continuation of what we require of people as simple and as easy to access so that we can fund more community-based organizations. We were able to do that during COVID, and we want to do that going forward. We think that's where the action is, frankly, in a lot of ways. But look, there are certain things about federal grant making that are what they are, that I can't change, that they are what they are, and they're complicated, and they require a certain level of financial management, sophistication that a community-based organization just might not have. And so we're continuing to try to identify other strategies to make sure our resources are getting to the community-based organizations that need it the most. In the meantime, we're using the levers that we have to fund community-based doula programs, and we've looked at it not just at training programs, but also at what is the economic model to make it possible to have a career as a community-based doula. I mean, when I used to be the Human Services Commissioner in New Jersey, and when I would meet the people we were training, they were like, oh, I'm an EMT, and I'm a doula, and like, people had all of these incredibly stressful, incredibly complicated jobs that were all somewhat intermittent. And that's a very difficult way to sustain what we know is a really important part of the workforce. And so those are some of the work, that's some of the work that we are focused on and really building our grant programs around.
Can we put our hands together for the panelists? So this has been such a great conversation. So thank you so much to HRSA Administrator Johnson, Dr. Carole from March of Dimes, and Rose Mitchell for sharing her professional and lived experience with us. I think we've all learned a little bit more about access to maternity care in the United States and how it is affecting maternal and infant health. Thank you to March of Dimes for sharing the report. We are grateful for their commitment to health equity for every family, regardless of where they live. And we are so grateful that you joined us today, those that are in person and online. Thank you so much again. To learn more about access to care, where you live, and to get involved, visit marchofdimes.org/MCDR. That's marchofdimes.org/MCDR. To learn more about HRSA and its resources, visit HRSA, HRSA. Yeah, we live in these acronyms. I had to learn them when I first came. It was really simple. It's like ASPE, ASPA. Okay, so visit HRSA.gov, HRSA.gov, and to get involved with the maternal health work we are doing at the Partnership Center, where I am privileged to direct, namely our newly launched Moms Tour, Maternal Outcome Matters, targeting cities that have high maternal and morbidity rates, and to connect women to postpartum and prenatal to services, resources, and connecting them to the village they didn't know existed. So to partner with us, please email us at partnerships@hhs.gov. That's partnerships@hhs.gov. And the last thing I want to say, and I think we all echo this, that as long as, there is breath, there is hope. And many years ago, I adopted this statement, what angers you is what you're assigned to solve, and what saddens you is what you're assigned to heal. So let's continue to grow the village until the U.S. becomes one of the safest places for women to give birth. Thank you for joining us.